We are starting our workshop, Urogynecological workshop, with our first speaker who is very dynamic, pioneer in laparoscopy in MP. And I'm really proud to have her here. She has found some time from her busy schedule for us. So we welcome you, Dr. Maneesha, for the workshop. So laparoscopic Burch, she will be covering tips, tricks and pitfalls. We know that Burch, it looks very easy, but when we perform it, definitely there are tips and tricks. And who else other than Dr. Maneesha? We welcome you, Dr. Maneesha. Please.
So, excuse me. प्रोजेक्शन नहीं हो रहा. मैंने कहा था आप उस कनेक्टर से जोड़ दो. वो प्रोजेक्शन तब अच्छा खासा हो गया था. हाँ हाँ, मैंने आपको कनेक्टर दिया था. And I'm extremely happy today to start the urogynecology workshop. Urogynecology, when we were studying, was not an entirely different discipline, but it has evolved into a huge discipline now, considering the volume of health disorders that happen into this particular discipline. Now, we'll be talking about laparoscopic Burch colposuspension. And before we talk about laparoscopic Burch, let us understand what is the mechanism of continence. We need two things from the urinary bladder. One, it should have a good storage. Two, it should have a controlled voiding. Anywhere where the storage has a problem or voiding has a problem, we land up into incontinence. Now, this incontinence could be urge incontinence, stress incontinence, and broadly speaking, overflow incontinence. Overflow incontinence is precisely because of storage dysfunctions usually. Now, it's a complex coordinated system between the detrusor muscle and urethra. Understand two things, that detrusor muscle and urethral muscles are different, unlike intestine where the sphincter comes as the confluence of the muscle from the bowel wall itself, which is not so in the urinary tract. So what happens is, there is something called as detrusor urethral dyssynergia. Now why am I specifically mentioning this point? Before we start any surgical procedure, we should understand that for any anti or any continence surgery, we require that the dyssynergia should not be there. So how do we evaluate it? Ultrasound, clinical diagnosis and urodynamics. So this is extremely important. Second thing is pelvic floor muscles. In female, continence is largely driven by the tone of the pelvic floor muscles also, which is not so in males. They have a long urethra, whereas female urethra is just 4 centimeters. Neural and vascular supply. We understand that neural supply, one of course is the local, other comes through the detrusor, third is through the spinal cord. Now, if there is injury at the spinal level or if there is an injury at the local level, the result is always the same, and any kind of neural dysfunction cannot be corrected with any continence procedures. So before we take up a patient for any kind of anti-incontinence surgery, we have to find out that what is the level of problem, so that we are able to counsel her that with this procedure, this is the relief that you are going to get, and this is something that you will have to bear with. Now, retropubic urethropexy or Burch colposuspension, a brief about the history. We all know that it started with MMK procedure. MMK went into disrepute because the suspension point was just at the pubic symphysis. That causes significant osteitis pubis and patients kept on coming in pain. And therefore, the search for another suspension place. Now, in 1961, Sir John Burch actually started doing Burch colposuspensions. Burch was initially not done for stress urinary incontinence. If you see the first paper of 1961, Burch was initially done for the correction of moderate cystocele. In the bargain, the fraternity realized that it is correcting the continence as well, and therefore they started searching for or propagating it for an anti-incontinence procedure. Now, the first time when Burch was performed, it was not fixed to the pectineal ligament. It was fixed to the arcus tendinous fascia pelvis, the famous white line that Tillins talks of, which we rarely see vaginally but laparoscopically seen beautifully. Arcus tendinous fascia pelvis is the fascia formed by the confluence of the fascia of levator ani and obturator internus muscle. Now this is something very important. Now this fascia is extremely important. This is one of the suspension points for the paravaginal repair also and anti-incontinence mechanisms also. This point was later changed to Cooper's ligament, which is pectineal ligament, from arcus tendinous, precisely because they wanted a little stronger support. So the principle of all urethropexies is essentially to prevent the postero-inferior rotation of the urethra on increase of intra-abdominal pressure. Now, the theories of continence per se are not understood well, and hence the procedures also do not have a very defined principle behind it. Basically, it evolves around two things. One is to suspend. When suspension does not work, the other is to support. So when you support, you think that the continence is at the level of mid-urethra, which is the principle for the transvaginal or transobturator tapes. When you suspend, you believe the continence is at the level of bladder neck. So retropubic urethropexies actually work at the level of bladder neck. Now, this is what I was talking about. Good old days when we used to do Burch Kolper suspensions, I remember my teacher Vivek Joshi would ask us to elevate the vagina. However, it was never a good idea because he would sometimes pass the needle through our glass. So actually, it is important that you should be doing it yourself to begin with, to understand that how much of the vagina is included. The amount of vagina that you include in your suture should be just short of vaginal epithelium. A flimsy suture or just some bites on the suture will not cause any kind of support because this is essentially a dynamic sling. It is going to be subjected to various kind of stress and distensions. So this is basically the principle. Now, the anatomical change that we want to desire from a good Burch Kolper suspension is that the distance between the bladder neck and the pelvic floor or levator ani is shortened. So whenever there is an increase in the intra-abdominal pressure, the urethra does not rotate postero-inferiorly and there is no leakage. The procedure has been tested for last almost 50 years, went into disrepute because of the invasiveness of Cherney's incision. However, with laparoscopy, it came back again, and in year 2000s, the tapes also, which were less invasive. However, there are restrictions. The indications would be talked later on. That is not in my talk. Briefly about complications. This does not happen laparoscopically anymore. But yes, in open Burches, obese patients, this used to be a huge problem for us. Largely because of the injury to the paravaginal veins when the surrounding fat is not cleared completely. So always clear the fascia completely to avoid any kind of hemorrhage. The incidence is 0.7 to 3%, and a good surgical exposure will always prevent hemorrhage, as is the case in any anatomic area. Visceral injuries, unlikely to have bladder, ureteral injuries, it are rare. They started happening in laparoscopic Burch more commonly when people in the initial phases had difficulty in suturing in closed spaces and started using meshes, tackers and tapes. This causes extensive denudation of the or laceration of the detrusor muscle, as it's a very broad surface area, and therefore the bladder and ureteral injuries. Initial cases do not describe, open cases do not describe, because unless you see the pearly white vagina, you are not going to pass your suture. Voiding dysfunction, well, per se, if you elevate it appropriately at the point of the pectineal ligament, and there is, how do you assess the fixation, voiding dysfunction? First is the bladder neck has to be identified well, with your catheter inside and catheter pulled outside completely. That Foley's position is the bladder neck. It should allow you 2 fingers between the pubic symphysis and the Foley's catheter. Laparoscopically, you cannot have 2 fingers, but your 2 fingers are essentially that instrument hinge. So that much should be the space to not allow any kind of obstruction. Secondly, your suture should be as lateral as possible. This was precisely pointed out by Tanhago. Your suture should be as lateral as possible. The more medial it is, the more chances of obstruction and voiding dysfunction, which is why voiding dysfunction is more common with TVTs than Burches, especially obstruction. So we have to assess preoperatively also that any patient who has high leak volumes, more component of urgency, and some kind of a neural deficit, which we can obviously make out in urodynamics, then these are candidates who will land up into post-operative voiding dysfunction, and we have supposed to do these investigations preoperatively so as to counsel the patient what she should expect from the surgical procedure. So a maximum urethral closure pressure of less than 20 centimeter of water, then it means that these are patients not suitable for any kind of suspension procedures. They may be suitable for pubovaginal slings or TOT-TVTs. Opposite compartment prolapse has been told that it causes enterocele, but it is not very clear whether the enterocele is because of the Burch per se or as part of a pelvic floor dysfunction of the patient. Now comes few things about whether that 2 suture technique is good always. 2 suture technique works well because you take a good amount or a good surface area of vagina as well as a good surface area of the pectineal ligament. Suture has to be non-absorbable. It could be ethibond or it could be proline. As lateral as possible, as I said. Okay, the time is up. तो ये गायब कैसे होगा? 23 minutes तो नहीं हुए. हाँ. Then elevation of the bladder neck has to happen. It cannot be, see why this point is important. Vaginal mobility is a prerequisite for Burch Colpo suspension. So when a patient has moderate cystocele, you can go on elevating the vagina and the vagina can come right beyond the pectineal ligament also. Because the idea is to take it to the pectineal ligament. But this will not correct the continence. It may correct the moderate cystocele. So it should be always at the neck, we have to elevate the bladder neck to form a hammock. Include all the vagina just short of the epithelium, no meshes, no staplers, and these have been studied. They are inferior to the 2 typical suture techniques, right? Now the recent trend is again now to include the arcus tendinous fascia and then elevate it to the pectineal ligament, giving it a wetter and a wider hammock. See, if we elevate something like this, it's a V-shaped hammock. If we take it like this and take it like this, it becomes a U-shaped hammock. So now let us come to the video. So first thing is, of course, we distend the bladder. The anatomical landmark here is definitely to see the median umbilical ligaments. See that border and you start dissecting for the fat between the round ligament and the median hypogastric artery. You go parallel to expose, and now if you see, you have to expose this fascia completely to prevent the blood loss. Be parallel, nothing will bleed. This is the pectineal ligament. Prevention of hemorrhage is actually the key for preventing all complications. So now you have to have a good exposure because the needle has to pass well. All the pink that you see is the urinary bladder. You have to keep it as medial as possible, Go deep, deeper, deep, and if you see, allow your carbon dioxide to go right up to the pelvic floor, keep on dissecting, desiccate all the blood vessels very well. Now you are elevating. All that yellow tissue has been exposed, medialized, And now what you see is the shiny pearly white tissue, which is the vagina. This has to be elevated to the pectineal ligament. See, the important is whatever yellow we are seeing should not be included in our suture. That will weaken our stitch. Secondly, we have to be careful about these vessels also. These need not be disrupted. These are disrupted, they are going to bleed torrential. They are basically paravaginal veins. So the plane is between that yellow and the pearly white tissue. We do not have to disrupt any blood vessel which is between the pearly white tissue and the yellow tissue. These are the paravaginal veins which bleed, not amenable to any kind of electrosurgery because they do not have collagen. It sticks and it spoils the feet. The stitch has to be as broad as possible. I purposely slowed the video here. As broad as possible. Listen, can you appreciate the breadth that it has? Essentially, suspension, you need a good breadth of the tissue as well. And if you see, I use a hammock, which means I actually take a figure of 8. Now you see the other tissue also. You see the vaginal veins here. All that is included in the tissue. So once this elevation is there, there is no scope of any kind of looseness there. It has, even if you see the vessels, don't withdraw your knee. When you tie, everything will stop. But if you take out in between, you will not be able to go in the proper way. That is what is most important. So now you see this, all that pink which is lateralized is basically bladder. So if you take the white tissue, pearly white shiny tissue, nothing is going to bleed, nothing is going to get injured. This is extremely important. We use proline around 7 to 8 knots, forward reverse. Now the bite on pectineal ligament. This has to now a little bit anatomy, Dr. Juhi will be telling, but all the suspensions are at the level of S2. S2 is the level of the iliopectineal ligament, S2 is the level of the levator ani confluence. Everything has to be suspended to S2 level. So if neither too high, because it will not serve any purpose, lower than this will cause obstruction. So it is to be left at the level of your Foley's bulb. Inflate the bulb with around 5 to 7 cc of saline. Pull it outside. Now where the Foley's bulb is your bladder neck and the hammock has to be like this. So therefore if you see, even this we take 2 stitches.
No interrupted suture also.
We can take 2 interrupted sutures also. But you know the second suture sometimes does not come as well as the first suture because precisely by that time there's some hemorrhage starts happening. So that bite is not adequate. Moreover, it's like, Burch, once you have elevated, then all the suturing should come in one go to have a clean, good amount of it. So this actually takes around 1.5 to 2 centimeter of the vagina and accordingly takes around 1.5 to 2 centimeters of the pectineal ligament also. Do not brush on the bone. Do not brush on the bone, it is painful. You pass your suture smoothly through the ligament. It will never be. You brush over the bone, you will find difficulty in negotiating. You cannot suture on the bone. You can easily pass the needle through the ligament. But if you brush the bone, it is always painful. Your bite is adequate, it tears and it bleeds. And bone anyway is not the acute. Bone anyway is not the suspension point. So this. So the same thing is done at the other side also, you can appreciate. Now, always the peritoneal defect which is created should be sutured. Those two eyes should always be sutured. The principle ki peritoneum need not be sutured does not hold very true here. I'll tell you the reason. Overhead is the pubic bone. It's a small defect. We have created a raw surface area. It's a closed cavity. There have been cases that the small bowel goes and gets stuck. Large bowel cannot. This leads to subacute obstruction kind of features. So always a Burch wound, space of Redzia should always be closed, be it open or laparoscopic. Even if 1 or 2 patients land up in SIO, we've had our history. It's like that. So this is the final picture. We of course did the. अब ये और ये match नहीं कर रहा है. What I am seeing here and what is seen there is not matching. ये जो यहाँ चल रहा है वीडियो खत्म हो चुका है पर ये भी पीछे ही चल रहा है. So Burch remains the gold standard. Vaginal mobility is essential and a prerequisite. It is a choice in women with limited vaginal access. क्या करना चाह रहे हो? ये स्लाइड को प्रोजेक्ट कर दो. हाँ. Then always avoid women with high post-void residual volume. Any patients, what is the prerequisite? Always assess that if she has a high PVR. Be very cautious of any incontinence procedure, anti-incontinence procedure to be done in diabetic patients. Assess the PVR precisely because it is going to help us in post-operative outcome explanations. So छोड़ दो. आपको हटाना नहीं था भैया. It is not in the presentation mode ना. तो आप presentation mode. अब वो वहाँ कनेक्ट नहीं हो रहा है. It's gone again. ठीक. So Burch remains the gold standard. Vaginal mobility is essential because it has to be available. It has to be elevated. Secondly, but there is a difference between vaginal mobility and vaginal access. When there is difficulty in vaginal access, always choose Burch. When there is difficulty in vaginal mobility, choose TOT and TVTs because they don't require mobility. On the contrary, they require access. So avoid women in high PVR, MUCP I told you, because this particular part is suggestive of intrinsic sphincter deficiency. Your patient will be never happy after an anti-incontinence procedure. When women leak large volumes, urgency should be subjected to urodynamic studies. We always need high volumes and high leak volumes and high PVR need to be evaluated preoperatively by urodynamics. Now always perform Boney's test if your patient does not have access to urodynamics, and do an empty cuff test in supine position. Now if a patient after emptying bladder in supine position leaks a very small amount of small volume of urine or dribbles, she has ISD and not SUI. So even if you are doing a procedure for SUI, which is Burch or TOT TVT, you will always have to tell the patient that this symptom of leak may be decreased but may not be cured, because it will take care of your urgency part, stress part, but the urgency will always be there. So success of the procedure depends on the case selection, counseling and the technique which we discussed. So thank you, and if there are any questions, I'll be ready to take.